What makes it different is that I work in the East. You need to look beautiful for your ethnicity.
How do you compare that now to the craze of a deep plane facelift that's going on?
Me get much more accurate result, fewer complications, and of course there's this new dimension of skin quality.
Eastern facers are looking more westernized. Westernized may be looking more Eastern. You know, I developed my skincare line in Korea and I spent some time in Korea.
We have different tools, but with those same tools, every surgeon, every dermatologist is going to get a different result from his colleagues. We had to pull it to the ear because that was where we hid the scars.
Young people are getting into these biostimulatory fillers and then they're almost becoming over biostimulated.
I practice in Singapore. Most of my patients here are Asians, whether they're Indians, Malays, or Chinese.
Feminine faces for a masculine face. And it's really interesting to see this blending of beauty. What's your take on that? I'm Dr. Anthony Rossi, and this is Give Good Face, a podcast focusing on skincare science, and how to maintain and shape a healthy lifestyle. Today, I'm most fortunate to have Dr. Woffles Wu, a world-renowned expert plastic surgeon from Singapore. He's sought out from all over the world, from Asia to the Western Hemisphere. He really is the guru of all things aesthetics. I'd love to take a deep dive with him today about his practice, about what he sees, both from the past and the future of aesthetics and beauty. Welcome, Dr. Wu. How are you?
Hi, Anthony. It's a great pleasure to be on your podcast. I haven't given many of these before, so I'm ready to take the dive with you. Shoot
Thank
away.
you. I mean, I was most fortunate to meet you fortuitously through an event overseas, and I was just taken aback by how knowledgeable you are, but also how refined your aesthetic is. And seeing your work over, decades really made me, a believer in your techniques. And I use those today. Everything from Microbotox to the subtle enhancements that you do with non-surgical treatments like hyaluronic acid fillers. I just think it's quite remarkable. Can you just tell us, beginning, like, how did you start, and how did you start to develop your techniques, including the Woffles Lift, which I'd love to talk about as well?
Yeah, so I think a lot of things are serendipitous, and it's just about being in the right place at the right time. And if we go back to 1995, I had just been made a consultant in the public hospital. And
In Singapore.
In Singapore, yeah. And my boss at the time, Professor S.T. Lee, he was quite forward-thinking, and he said that plastic surgery needs to have an aesthetic division. So we can't just be doing reconstructive work all the time. You needed to have a good department that could handle aesthetic cases. So he put me in charge of that and kind of gave me a free hand. 1995 was when Botox was released, and it arrived in Singapore, and we were just trying to figure out how to use it. There were no instruction manuals at the time. It was just a little bottle sitting on the desk. So we really had to innovate and come up with all the parameters that we are familiar with today. Now, prior to that, in the late 80s and early 90s, we'd already kind of started with some fillers. So there was the old Zyplast collagen, and we were doing that in people's lips and nasolabial lines. And of course, it didn't last very long because it was of 1 month duration. And then when Restylane came on the market, that kind of changed things a little bit, because now we had a filler that could last at least 6 to 8 months. And that created a lot more versatility and opened up the doors to be able to do things like sculpting the face and in all the different areas of the face and nose. And then after we combined the fillers with the Botox, I realized that we were entering a new phase of aesthetics, because now we could really give our patients the non-surgical approach that they'd been asking for all these years, but we never provided because there was only surgery. So suddenly we had fillers, we had toxin, and shortly after that, in 2001, I invented the Woffles Lift, which was a barbed suture sling. I talked about it many times in the States at many of the ISAPS meetings and even in the California Society meeting. And these threads are kind of put in through a needle that goes vertically upwards towards the temple, and then you insert the thread in, and then you put another needle adjacent to it and come out through the same hole, and you put the other end of the thread. So literally you end up with an inverted suture. And on the suture are little barbs, so you can pull upwards and suspend the tissue to the temple area. And I thought this was important because I trained as a facelift surgeon with Bruce Cornell, and I thought that it was just counterintuitive to be pulling the face backwards towards the ear. And of course, we had to pull a bit to the ear because that was where we hid the scars.
Mm-hmm.
But it was kind of like a misnomer because I felt that, well, if you're pulling to the ear, whatever is below it would have a good result, and that's the neck. So it's actually appropriate for a good neck lift. But when it comes to the face, you're pulling laterally or you're pulling to the side. And that's kind of like when you pull a tennis net. You can pull it as tightly as you like, but it will always have that little dip in the middle.
That annoying dip.
That annoying dip, or like a clothesline. So in our case, if I just demonstrate, if you pull towards the ear, you have to put quite a bit of tension at the ear in order to get the jowl to lift upwards. But if you do it this way and you go directly to the jowl and you lift it to the temple, now you get a vertical lift, you see. And a number of us back in 2000, we were looking at this vertical lifting vector. There was Patrick Tonard in Belgium who came up with the max lift, and that was also a vertical suspension. So there are a few things that we kind of agreed on that hopefully would be paradigm shifts in the way we treated the aging face.
So changing the vector of the lift was really key.
Yeah, because when you lift directly upwards, you don't need to put so much tension on the ear. Then you don't get pixie ears, you don't get deformities, you don't get keloid scars. And remember, I practice in Singapore. So most of my patients here are Asians, whether they're Indians, Malays, or Chinese, and they tend to have a greater tendency to form a keloid. So the minute you put tension on a scar line, you end up with a keloid, and then you've got to deal with that post-operatively for the next couple of months. The thread lift was a perfect solution, and then I came up with this concept of non-surgical facial rejuvenation, which is to relax with Botox, to restore volume with the HA fillers. And we also had a few permanent fillers back in the day, but I don't use them anymore. And the third thing was to redrape. So 3 R's. And then we looked for a 4th R, and that was the non-ablative kind of skin treatment, such as intense pulse light, and there was a device called Cool Touch back in the day. And then gradually we merged with thermage, alt therapy, etc., etc. So now we had the 4 R's, and I called it the 4R principle. So relax, restore, redrape, and the 4th one is resurface.
That's amazing. I mean, I love that approach because it's really encompassing all aspects of both intrinsic aging, but also extrinsic aging, which are the two main drivers of aging for us.
Right. Yes.
That's wonderful. And your take on the new sort of non-surgical thread lift that you invented, as well as these new techniques for non-surgical lifting and restoring, how do you compare that now to the craze of a deep plane facelift that's going on?
I like the deep plane facelift. I like the simple smash lift. I like the deep plane lift a little better because it gives better control of the nasolabial area and the mid-malar area. So I'm a big fan of that. I'm always happy when a patient comes in and says, I want a facelift, because I like to do facelifts. But once you've invented something that is out there on the internet as an alternative to a surgical facelift, suddenly you get inundated with a lot of people from around the world who say, well, I don't want a facelift, but I want to have a facelift type result. So can you do that with the threads? So I keep on getting patients who come for threads when I do want to do a deep plane facelift.
Yeah. So it is a compromise between patient and surgeon, I would imagine.
I think it is. Look, as plastic surgeons and dermatologists, we need a wide armamentarium, a wide variety of tools to choose from, because patients are never the same. There are some patients who are more risk averse and they don't want to have a surgical complication. And there are others who are a little bit more risk takers, and they're willing to have surgery, even though we show them pictures of complications, whether it's eyelids, noses, or faces. We show them the complications, but nobody goes into surgery thinking they're going to get a complication. They all think they're going to get a fantastic result.
Of course.
And so I just like the fact that we've got different techniques for different poles of the patients, those who want and those who don't want surgery.
And, you know, you have seen so many faces in your career so far, and you're still seeing more. And when you approach someone's face, do you categorize as facial shape? Do you categorize as ethnicity? How do you take that approach? Because I think we're seeing a lot of homogenous blending of beauty now, right? So
yes,
Eastern facers are looking more westernized may be looking more Eastern. You know, I developed my skincare line in Korea, and I spent some time in Korea, and the rise of K-pop has really changed the aesthetic. You know, some of those K-pop stars have very, you know, feminine faces for a masculine face. And it's really interesting to see this blending of beauty. What's your take on that?
Well, it's changed a lot. I mean, the beauty standards, they've always been quite classic in terms of facial proportion, the thirds of the face, the blending of the eyes and the nose and the lips and the shape of the face, whether it's squarish or oval or heart-shaped. All of these things, I think, are very important. But when I see somebody, when they come into my clinic, the first thing I instinctively do is try to size them up for what I think would make them look better. Sorry, there's all this pinging going on. I don't know how to.
You're popular.
So no, it's a gut instinct, really, and that's why when a lot of fellows come through my doors and they say, "Well, how do you choose?" And I say, "Well, I don't really know how I choose. I have techniques which I know I can do, but when I look at the face, I kind of zoom into what makes that face tired, what makes that face not so fresh looking, what could we do to improve the contours." And once I have evaluated what it is that they need to do, then we'll look for the appropriate technique. And then we'll ask them, do you want to do this surgically or do you want to do this non-surgically? And if you're going to go down the non-surgical route, then you need to be aware that you're going to have to come back every couple of months to do touch-ups. Whereas with surgery, there's a greater inherent risk, but you'd get a longer runway with the result. So these are the things. The second thing is about ethnicity. I think ethnicity, you said it, there is a blending. And I came up with a facial scale. I think you may have seen that before, the facial scale, which is very simple. And it's just a scale that goes from 1 to 10. Anybody can be placed on that scale. So you can ask somebody, how do you fit onto that scale? And they may say, well, I'm a 4 or a 5. And then I'm doing an assessment and I think there may be a 5 or a 6. So we'll write it down. Anybody can be placed on that scale. So if you're not so good looking, you're 1, 2, and 3. And if you're average good looking, you're 4, 5, 6, and 7. And if you're good looking, you're 8, 9, and very few people are 10. So most people are about 7, 8, 9, with 10 being reserved for very, very special faces. And the aim of everybody is to move upwards on that scale. Now, the interesting thing is, when you look at different ethnicities along this scale at the lower end, let's say the 1, 2, 3 area, people kind of take on the typical shapes of their ethnic origin. So an Asian face would be very flat, very wide, and without that angularity, without that anterior projection. An African would look like an African, an Arabian would look like an Arabian, an Eastern European would look like an Eastern European, and so would a Jewish person. So it's very characteristic of their ethnic type. But now when you move across the scale towards 8, 9, and 10, suddenly people start looking more similar. And that's because we appreciate what the beauty aesthetics are. And as we get to 8, 9, and 10, people's faces are becoming more classical. They're getting more oval. There's getting more projection in the mid face. There's vertical height. There's a narrowness to the lower face. And whether you're Indian or Chinese or Korean or American or English, everybody begins to look a little bit more appealing because they're kind of in the same category. So what makes it different is that I work in the East, and I'm always telling my patients, you need to look beautiful for your ethnicity. You need to be at the 8 and 9 level of the scale, but you don't necessarily need to look Caucasian. And this is a strange thing, because when I was growing up as a plastic surgeon, the beauty ideals of the Western face were kind of thrust down our throat. Because that was all the data that was available, and it was proportions of the Western face. And rightly or wrongly, in the 60s and the 70s, many of the patients, and I think many of the doctors themselves, thought that Asian people, in order to look beautiful, needed to look Caucasian. Hence, we started having the double eyelid, we started making the nose higher, longer, sharper, making the chin more chiseled or sharper in a female. And we were creating some bizarre results, actually, in the 60s, because it was just overdone. You can't take one Western feature and plonk it into the middle of an Asian face. So you've got to kind of blend everything together and retain their ethnicity. And one of the very interesting things is, of course, the epicanthic fold. Here in my part of the world, we do a lot of operations to remove the epicanthic fold so that the eye looks longer and a little bigger. And some people will say, well, isn't that westernization of the eye? And it isn't, because I did a study which is going to be published soon, hopefully, on different kinds of Asians. And I found that, number one, only Asians, especially Orientals, Chinese, Japanese, Koreans, only they have epicanthic folds. You don't find any white person with an epicanthic fold. So the minute there's an epicanthic fold, it probably means you've got some Oriental origin.
Oh, wow. That's interesting.
And then when we looked at a series of, I live in Asia, so I see Asians every day, and I'm always looking at their eyes and trying to see whether, oh, that one's a single eyelid. Oh, that one's a double eyelid. Oh, that one has kind of like a triple eyelids and a sunken sulcus, which looks very Caucasian. And this person has an epicanthic fold, and this person doesn't. So there are many ethnic Chinese, Korean, and Japanese people who don't have an epicanthic fold. And in fact, if you look at my eye, I don't have an epicanthic fold. Well, I have a very tiny epicanthic fold, and this is called the type 2 configuration. I'll send you some of that information. I've got 6 types of epicanthic anatomy.
And you can surgically operate that and change it.
Yeah, we can surgically operate that. So when I remove somebody's epicanthic fold, I am still mindful to make the eye look Asian, but like a beautiful Asian eye at the end of the scale, the 8-9 scale, rather than at the bottom end where it makes them typically look very Asian. They used to use the terms Mongoloid, so Mongoloid eyes. But today I think that connotation isn't very PC.
Yeah.
So Asian eyes, fox eyes, all of these things are things that we take into consideration when we're doing our preliminary beauty assessment. And I like to spend a lot of time with the patients, kind of getting them to understand what beauty is and trying to understand how they want to embrace beauty, or whether they're just doing it because it's like a party trick, or they just want to look good for a wedding or some event. Is it something that they want to incorporate into their whole lifestyle? Because I think if you're going to be serious about beauty, you do need to think in depth of all the things that you want and how you want to age. And I think today, a lot of people want to age the best way they can. Few and far between are the patients who say, oh no, I actually don't mind looking bad as I get older and age. I think most people would say, I'd like to age. I'm not trying to look 20, but I want to look like a fresh 60 or a fresh 70 or vibrant 80-year-old guy or girl. And that's what I try to discuss with my patients, rather than giving them a typical outcome, which is like, oh, I want to look like a 25-year-old. I mean, that's very difficult to do.
Yeah. It's also incongruent to, the rest of their body. So if you're a 60-year-old or 70-year-old and you want a 25-year-old face, it's very incongruent to neck down as well. So
Correct.
We have to be mindful of both.
Tight, terrific face, and then you've got the saggy boobs, and everything is kind of spilling out, and the body can look old as well. And the worst thing, of course, is when they get hunched, right?
Yeah.
The neck hunches and goes forward, and no matter what kind of facelift you have, when you see somebody with a hunched neck, it just makes them look a little old.
Yeah. I'm going to sit up more now.
Yeah, so am I.
It's interesting that you said that, because it's really, with social media now, and you wrote your book, Life in Plastic, and social media has just, really boomed the whole plastic surgery and cosmetic surgery and aesthetic market. And we're seeing a lot of trends now. And so trends, for better or for worse, they're out there. So like you mentioned, the fox eye or the epicantal tilt, the invisible brow lift that we're seeing a lot now on like the celebrities, whether they have them or not. And we're also seeing a lot of combination surgeries take on all at once. So, recently, we just seen a new face on like Lindsay Lohan and other celebrities. And it seems that they seem to be having so much work done at once, like a rhinoplasty, an eye lift, a brow lift. This is all speculated, but what do you think about these trends? Have you seen them come and go, or do you think they'll last for a while?
I've seen trends. There have been different kinds of trends. Like I said, back in the 70s, there was this obsession with Asian women to have a really high double eyelid, maybe a centimeter high. And if you look at that today, it just looks so weird. But it was trending back then, and we have a lot of older individuals now who had that surgery, and they walk around and it's like a stigma. And then to an extreme, if you go to China or Korea, everybody wants to look like a pixie now, like an elf, with a very sharp kind of lower face and ginormous eyes and a cute little up-tilted nose. And these are trends, because when I go to China and I see some of these patients who've been operated on in a very extreme way, it's almost like you're looking at a new species of human being, because they all look the same, but they don't look like ordinary people on the street. It's like something that has been created. It's a new species, really. And there's another interesting trend that has come out of Asia, and as you know, influencers are very big here. And all of them want to look a certain way. So it's this very cute pixie kind of elfish kind of look. And I think because people were taking a lot of selfies and taking pictures of themselves using the front camera on their phone, which is a wide angle lens, they would get a picture where the ears were kind of pressed to the side. And you can try this yourself if you use the phone this way, or if you use the phone this way. Your facial proportions will change.
And that's because it changes the focal point of the photo.
Correct. Yeah. So when these influencers realize that, hey, I don't see my ears in this picture, then in the last 2 or 3 years, there has developed this trend where people are pumping fillers behind the ear to bring the ears forward. And then we realized that if you put a lot of filler behind the ear and into the back of the skull, you can actually pull the jawline upwards. So these are pushing the boundaries of what we do, but it's quite trendy at this point of time. And I mean, the general trend for most of the patients is the realization that you can look very beautiful in that 8-9 range just by tweaking the way individual features come into proportion with others.
Yeah, and that's such a strong point. The proportionality, I think, is so important because I think that's the hardest sometimes for patients to realize is they may want bigger lips or they may want like a stronger nose or a stronger jawline, but they don't necessarily see the proportionality, how it fits in with the rest of their face or their neck. And I think it's up to us to really help them along that journey to make them understand that all things exist in a ratio.
Correct, correct. And if you look at Asian patients from China to Singapore to Malaysia, actually, each region wants different things.
How so?
Here in Singapore, we're not so into this extreme elfish looking face. In China, it's a very big thing, and in Korea, it's a big thing. And of course, you mentioned K-pop earlier, and there are all these guys with this almost feminized face, and it's great if you're in a K-pop band, but
Yeah.
if you're just a normal worker and you're walking to office every day and you've got this K-pop kind of look, it's kind of strange.
It's
So
out of context. Yeah.
it's out of context. In Singapore, I get very few people asking me to look like this, but when I go to China, I get a lot of people asking me, "Can you give me this look?" So different countries have a different emphasis on how they want to look. Here in Singapore, I think people are quite mature. They just want to tweak their features, look a little younger, look a little fresher. Fresh is a very important thing in my part of the world. They want to look not tired. They don't like eye bags. They don't like shadows in the mid face, and they can live with a square jaw. They don't have to have a totally oval kind of face. So I guess our job as a plastic surgeon is to kind of guide them on their journey and help them make decisions. I mean, we can't choose the procedures for them, but at least we can educate them, and then they can make evidence-based decision.
That's amazing. In the Western part, we see a lot of men asking for like these very, very square jaw lines, very sharp, angular, almost Neanderthal looking, like I've seen some people like pump up their jaw lines, to make it so square that it actually is bypassed their bizygoma distance or their bitemporal distance. So it almost looks like a trapezoid. And, that also is, quite garish as well. Yeah.
I mean, they look like characters from the Marvel universe. I think there was one guy there whose head is narrow at the top and then kind of very broad, and I think he's the villain in the film.
Yeah, exactly.
Neanderthalic, very masculine, hyper masculine.
Yeah.
I get them occasionally here in Singapore. And sometimes it looks quite appropriate. So if I think that they're not going overboard and that the look is something that is achievable, is safe, and then I won't say no to it. Like I've been known to put quite a number of cc of fillers on the jawline to drop the mandibular angle and to change the the whole angle of the mandible so that it gives you a squarer, more masculine look, and then to square up the jaw here. And I've done that both with implants and with fillers. But of course today, when somebody comes in and they're not really sure what they want, but they know that they want to change, I guess the easiest thing is to give them a filler and say, well, if you like this, we can discuss whether you want to make it into a surgical procedure down the road.
Yeah, I think that's so exciting because we do have these non-surgical treatments that can really give you a glimpse of what you could potentially achieve with something more permanent like an implant.
Yeah, that's right.
How did you develop the Microbotox technique? I found that fascinating, especially for your neck. Botox is going to be approved it was approved for the neck and the platysma here in the US. But you've been doing Microbotox for quite some time.
Yeah, since 2000, actually.
Yeah.
And along the way, there have been a number of things that I've kind of invented or pioneered. And the first was actually the use of Botox to reduce the masseter.
Yeah.
And prior to some of the articles I had written, there were a couple of articles from the dental literature where they were injecting Botox into the masseter just to decrease the power of the bite, so that it didn't get temporomandibular joint pain or crunching or clicking. Then I decided that, if we injected it in the masseter, if we were able to inject the muscle sufficiently, well, then the bone might remodel. Because we all know that there's this theory, it's called the bone muscle matrix theory, and it's by Moss and Enlow and Randquist, actually. It's from the 70s and 80s. And it says that the bone, or the density of the bone, is a result of the muscles that are around it. So we know that when we get older, we always tell our aged parents, oh, you need to go and get some exercise, lift some weights, because that muscular activity helps to activate the osteoblasts in the bones. And we also know 20, 30 years ago, if you had a fracture of your femur, there were no plates in those days. You were just put into a plaster cast. And 12 weeks later, the plaster cast would come off and the bone would be healed, but it would be like 1/3 the size of the other leg because of disuse atrophy. So I thought, okay, if we're going to go with Botox, I'm a craniofacial surgeon, so I said, maybe I can get face changes by putting Botox at high doses and very frequently into the muscle. And so we were able to get these really dramatic changes to the lower facial shape using Botox. And then I realized that the parotid gland also has ACH receptors, and it's 100% ACH receptors. So I started injecting Botox into the parotid gland and found that that could shrink as well. So now we're having two tools to reduce the width of the lower face, Botox to the masseter and Botox to the parotid. And then as we went on into the late 90s and the early 2000s, we were putting 0.1 boluses into all these areas which we see. And I did a little starch iodine test on my forehead, and I injected different volume sizes. And I realized that the bigger the volume, a 0.1 mil volume, when you inject it into the forehead, it kind of has an effect of about 2.5 centimeter.
It's a diffusion
diameter. It's a diffusion diameter. So we were seeing a lot of complications because people were injecting 1 finger breadth from the eyebrow. And of course, you will hit some of the corrugators, but you'll also diffuse upwards into the brow, into the frontalis. And then doctors would be asking, well, how come I can't get a brow lift? Well, because you knocked out the frontalis at the same time as you knocked out the corrugators. So I thought, well, if we really want to be able to get a brow lift effect, then we should give the injection to the muscles that depress the brow, but leave the other muscles to be free. And the only way to do that was to reduce the size of the droplet, because if you reduce the size of the droplet, it doesn't spread so far. And then I started moving towards injecting at the skin level, because if you put let's say a 0.03 or 0.04 droplet, it's only going to penetrate 2 or 3 millimeters in the subdermal plane. And so you'll just get a little bit of weakening of the muscles. But more importantly, we started seeing changes in the skin. So it was affecting sweating, it was affecting sebaceous activity, pores became smaller, rosacea was reduced. Even people with syringoma around the eyes could be treated with this Microbotox. And then I kind of refined and developed that technique and said that, well, Microbotox is like shooting bullets everywhere instead of like releasing a bomb and it's killing everybody in its radius. So it made me get much more accurate results, fewer complications, and of course there was this new dimension of skin quality that we'd never thought about. But now it's become standard. Everybody's writing about Microbotox and how we can get rid of pores and rosacea and acne. I mean, that's another one with the acne.
Yeah. And achieving that like glass skin effect as well.
That glass skin effect. Yeah. Then I extended Botox down into the neck, because you realize that muscles of the face and the neck are unique. They belong to a group called the panniculus carnosus. And there are very few muscles in the body which actually insert into the undersurface of the dermis. And the facial muscles, the SMAS muscles, the orbicularis, the corrugators, they all have little attachments that come up to the skin. And this is what holds the skin down, so that when you frown and you get these very typical grooves on the face, or crow's feet, or even here in the marionette lines. And in the neck, if you get horizontal lines, those horizontal lines, if you do a facelift, you'll still see the horizontal lines, because that is the attachment of the platysma at specific points to the undersurface of the dermis. Now, if I can weaken that then I would probably be able to reduce neckline. So we started doing Microbotox in the neck, which was to improve the lifting of the jowl and the shape of the jawline, improving the cervicomental angle, the platysmal bands, and more importantly, the quality of the skin. I published that in PRS in 2015, and I think it's a reasonably well referenced article.
Yeah, very much so.
That was the one that I tried to put the whole systemization of Microbotox in, which dilution worked for the face and the forehead, which worked for the under eye area, and which one worked for the neck or décolletage. And try to give a little bit of science to it. And I'm really happy that it's become such a popular technique. I mean, now we don't even use the word Microbotox, we use Microtox, because there's so many tox around and they can all be applied in this micro droplet fashion. Just as an aside to that, when it comes to fillers, I mean, we've been using all kinds of fillers. I'm sure you have a ton of fillers in your clinic. But I can tell you, from hundreds of Restylane and Perlane and Teosals and all the different brands, I have finally found the fillers which I really like to use, and they come from the Vicross range. With Volite, is very, very soft. It's only a 12 milligrams per mil type of concentration, and it spreads like water.
Yeah.
So now that we have a filler that is so light and water-like, we can create much smaller droplets. So I've started developing my micro droplet therapy with fillers, and some of the lectures I give now are micro and macro droplets for the face. Where do you use a macro droplet and where do you use a micro droplet? And so there are many areas. You've got the tear trough, you've got the nasal, the marionette. I don't use fillers deep at the muscular layer anymore. I just do it tiny little micro drops all over the face, and that gives you an improvement in the skin quality, in the texture and the density of the face, which just makes you look healthy and like you've got that glass skin, as you mentioned earlier. So
yeah, we finally got that filler in the US. It's called SkinVive now.
Yeah, it's called SkinVive. It was just relaunched here.
Yeah.
And it's kind of like Lumigan and Latisse. I mean, Latisse was Lumigan. So I think it's going to find better traction now, because it's now being promoted as a skin booster and a skin enhancer. And I do think it's a very, very good filler. I think sooner or later, all the other companies will catch up when they see that this is such an expanding market for the skin quality. And all of them will come up with lighter and more malleable kinds of fillers. And then when we're talking about contouring the face, well, you're going to use something with a little bit more of a G prime. And so I default now to Volux because it has the least water absorption. And one of the things that we've seen in the last couple of years, especially in Asia, is all this cannula use and so much of the fillers being put into the cheeks that they've all become these puffy, what we call moon face, or in Chinese food, there's a pao. A pao is like a big bun. And so now people have this bun face, and it's just an overfilled syndrome. And I think that is because we've pumped so many of these high G prime, high water absorption fillers into the face that everything's just bloated up with time. And I don't want to create that in my patients. So I'm using very small droplets of Volux on the bone, and I'm using very small droplets of Volite under the skin or in the deep dermis of the skin. And I think that's a great way to move forward. So hopefully I'll come to the States and give that lecture soon.
You have to, because there's an epidemic of festoons and hydrophilicity and water absorption going on, because
it's terrible, isn't it?
Yeah. And I think people think that these fillers last a short time, but in reality, we know this when we're cutting open the skin, we see this filler last quite some time.
Years and years.
And you can
I
find
had one lady who had a deep sunken upper sulcus of the eye. And I put a little bit of filler into the sulcus, and everything became very beautiful. And I told her, I said, well, you're going to come back in a year because all the filler is going to resorb and you'll get those sunken eyes again. And you know what? It's already 10 years. And she never got that problem again. So what happened? Is the filler still there, or did something else happen? Is there biointegration? Did it act as a scaffold and then you had some soft tissue ingrowth into the filler? I mean, we don't really know. But all we can do as responsible doctors is really to observe all the results that we're getting, jot it down or keep it somewhere in your mind. And then when everything clicks, you can find an explanation for why these things happen. But we know that fillers don't just disappear in a couple of months. They can stay for a long time.
And they're powerful signaling molecules as well. HA is in itself a powerful signaling molecule. So
it is.
Yeah, there's things going on in the dermis, in the skin that, we need to learn from.
So I like HA products. Today, I think my practice has changed. Maybe when I was starting out in private practice 25 years ago, I was willing to use a wider variety of fillers. And in those days, there were fillers with PMMA or PLLA or PCL, or things have been developed through the years. But I've seen all manner of complications the minute there are particles that can't be dissolved. And some of them can be pretty annoying and difficult to correct. I'd rather inject something that I can dissolve. I'm not a big fan of this new trend. You talk about new trends, biostimulation.
Yeah.
Okay. I don't know whether you're into the biostimulation.
A lot of people here are, yeah. I think you have to be very cautious because young people are getting into these biostimulatory fillers and then they're almost becoming over biostimulated.
I saw somebody with, just today actually, with calcium hydroxyapatite filler. I won't mention the brand, but it was put into his horizontal necklines, and it was done a year ago. And he's got these beads all across his neck. So he's got granulomas there. And I think it's just a marketing type of thing, because biostimulation kind of sounds sexy and it kind of sounds very positive. But in actual fact, biostimulation is bioirritation, but you can't sell that term. You can't say, oh, this is a bioirritant, right?
Yeah.
So, but in reality, what we're creating in the face with these permanent particles is like how they develop cultured pearls, because they realize that a pearl is actually a response of the oyster to the grain of sand which was put into his body. And in trying to get rid of it or get rid of that irritation, it just created layers and layers of saliva, essentially, around it, and it becomes a pearl. And that was the basis of Mikimoto making his Mikimoto cultured pearls. They would get oysters and they would put grains of sand into them, and then they'd develop into these pearls. And I think we're doing the same thing with the face. We are telling patients that, you're going to get biostimulation, you're going to get new collagen, you're going to get lifting, you're going to get a brighter face. What do some of the patients get? They get yellowish plaques on the face. They get little nodules in the lips, nodules in the neck, in the tear trough. And I won't say all biostimulators, you need to be cautious of them. Some of them can be very good. But if you're out there as a doctor, I think you really need to analyze the product that is given to you and really think about it and what kind of long-term issues you could encounter, because these patients with complications can come back and haunt you 10, 15 years down the road.
Yeah, and I think young doctors really need to hear that, first, do no harm, right? And we really you need to know and understand the product before you use it. And there's going to be so many products that come out on the market, but we really need to be critical and analyze what's new, what the data is, before just going ahead and using it on patients.
Correct.
Yeah. Woffles, I could talk to you for days, for hours. I love talking to you, and your story about the pearl is just beautiful. I really value your expertise, and I hope we get to talk more. I hope I get to see you soon. I was in Singapore and I visited your clinic, which was amazing. Amazing. I just want to say thank you for being so open and honest and sharing your expertise with me, but also the world.
Well, it's a great pleasure, Tony, to be on your show.
Thank you.
And I hope that some of the stuff I've said will resonate with people out there and maybe get them to think about beauty and ethnicity in a slightly more cohesive, holistic way, and not just to categorize faces into certain baskets. What we do is an art form, isn't it? It's just the tools. We have different tools, but with those same tools, every surgeon, every dermatologist is going to get a different result from his colleagues. And that's where the artistic eye comes in. And I cannot emphasize this enough. I'm very worried when I get a fellow coming into my clinic and he's here for a couple of weeks or months. And I say, do you like art? And he says, no, I don't know anything about art. Do you like music? I don't know anything about music. Then I said, you do realize that plastic surgery is a creative field, right? And if you want to be good at what you do, you need to have an appreciation of beauty, whether it's a face, a handbag, a dress. You need to know what is beautiful. When you see something that's so beautiful, you say, wow, that was great. I mean, that's the kind of response we want to get. Beauty that takes your breath away.
Exactly. I mean, it's one of the reasons I love living in New York City, because walking down the street, your eyes just go everywhere. They can dart to beautiful faces, all different types of people, beautiful architecture. You know, it's an amazing, there's so many amazing places in the world, but I love calling New York home.
Yeah, I'd love to visit you more often.
Please, yeah.
It is such a long journey.
I know. But I do hope I get to see you soon.
Well, one thing you can consider, and your listeners can consider, I'm going to give a plug now for ISAPS, the International Society of Aesthetic Plastic Surgeons. And we're having the ISAPS meeting in Singapore,
nice,
June the 18th to the 22nd. And there's going to be international plastic surgeons, probably about 1,500 people coming in. And we're going to have a special section on Asian faces, Asian techniques by Asian surgeons for Asian patients. So I think you can pick up a lot of aesthetic tips and beauty ideals from these sessions. So that's happening in Singapore in June 18th to 22nd. Anybody who feels they want to learn more about this, please come. We'd be happy to host you.
That's amazing. Yeah. And I love visiting Singapore. It's such a beautiful place. Thank you. Thanks so much for listening to this episode of Give Good Face. Subscribe on Apple Podcasts, Spotify, YouTube, and wherever you listen to podcasts. And follow along on social at Dr. Anthony Rossi and at Rossi DERM MD.